Okay, Bismillah ar-Rahman ar-Rahim. Assalamu alaikum. I would like to thank everyone, the organizing committee and my colleague, and congratulate them for their great success and achievement. This morning I'll be talking about optimizing antimicrobial use. I've been asked to be fast because we're running out of time, so please cope with me. I'll be happy to entertain any question afterward, but I have to somehow I will do this in a quick way. At first, I would like to start my talk by outlining what I'm going to talk about. So I will be reviewing the evolution of antimicrobial stewardship. How did we end up with the antimicrobial stewardship program? Review the various antimicrobial strategies that's been used and recommended. Introduce the antibiotic care bundle concept. If I may ask, how many of our audience know about the antibiotic care bundles? Antibiotic care bundles. Anyone ever heard about this other than my team from King Abdulaziz University? What? Except for the experts in the room. Okay. Okay. So, and I'm going to highlight some of the performance measures that will help you to make sure that your stewardship program or whatever intervention you're doing to control the inappropriate use of antibiotic, it's really working. You have to document this, that it's either working or you're harming your patient or you have no different at all. Okay. Why do we care about antimicrobial use in the hospitals? Antibiotics are the second leading class being prescribed worldwide, and this has been shown even in early 1980s. And why do we care about that? When you have inappropriate use of antibiotic, as Dr. Abir kindly mentioned, you will put your patient at risk of... can you get this? I'm not used with... I'm not used with Apple, sorry. No. I want this one. So this one is the one up. Okay. Okay. So as Dr. Abir mentioned, we care about controlling the inappropriate use of antibiotic in our hospital because it will put our patient at risk of having multi-drug resistant organism, such as MRSA and VRE and ESBL, and that's old news. We have this from a long time ago. And now we're facing a bigger threat, the carbapenemase resistant, which is either KFC, and when this started in around 2005, everyone thought it's a big problem. And now we're facing another type of carbapenemase resistant with the new Delhi metallo-beta-lactamases, which make treating or managing some of the patients big challenge. The study was done by Coleman Rotestein, which is one professor I'm honored that I worked with in Canada. He's the leading or the godfather of ID transplant and one of the people who pioneers in the antimicrobial stewardship. So his paper that was published in 1998 showed that 22 to 65% of the hospitals antibiotic that use in tertiary hospitals is either inappropriate or unnecessarily, which is a lot. So you're putting your patient at risk of either side effect, drug-induced fever, Clostridium difficile, or emergence of new antimicrobial resistance. Also, it takes a lot of hospital budget. I know we don't care as a clinician, we don't care about budget. Who cares? I want my patient to be cured. But hospital administration cares. If you tell them, Wallahi, you're going to save around 50% of the money, this is your winning card. If you need your support, enforce upon some of the people, hard people, this is your winning card. And this is what we did, and I'm going to show some data from King Abdulaziz University. Okay, so how this started? In late 80s to early 90s, experts recognized that they have a bigger threat of having no drugs to treat infections, so decided to come with antibiotic control program. But as physicians or clinicians, we don't like to be controlled. You took our autonomy, our right to order whatever we want, so this failed right away. Then they said, okay, the name, they hated the name, let's call it antibiotic management program. That stayed from my literature review around 4 to 5 years, but this again failed. So they had to change the terminology to be more to reflect multidisciplinary teams, to have more input from all teams, and they called it Antimicrobial Stewardship Program, and that's what I'm going to talk about, and antibiotic care bundles. So what antibiotic stewardship program? It's a program designed that your patient will have the maximum benefit, will be cured in a timely manner without having side effect, whether it's drug-induced fever, whether it's toxicity, nephrotoxicity, whether it's selection of pathogenic organisms such as Clostridium difficile, you're killing normal flora, you end up with a C. difficile, or emergence of resistance like New Delhi metalloproteinase. You will never have antimicrobial stewardship in your hospitals if you have a crabby infection control practices. It has to go hand in hand. Antimicrobial stewardship program, you have to cover both in your infection control and your antibiotic ordering practices. What's the point if you control the antibiotics but you still have a crabby or a bad strains circulating throughout your hospitals because your staff hand is dirty. So no matter how much restriction you put, the strain will continue to be circulated. Effective stewardship, you have to be emphasized through your infection control as well. And at the end, antimicrobial stewardship, although we, as a physician, we hate that, but you should put budget in consideration. And as I said, this is your warning card. Okay, there are two core strategies that your hospital can use, one or two or both, and that's what we did, as again I mentioned now. So it's either prospective audit with intervention and feedback, and that's A1. What do we mean by A1? It's supported by a randomized clinical trial and shows it's effective. And effective in what way? It will improve the inappropriate prescribing behavior among your clinician. It will engage them in the decision making. You're not taking their autonomy. The problem with this one, you need staff to be 24/7 available to talk with each ordering physician about each antibiotic. And discussion may take an hour or two or 30 minutes, it depends. But studies show this is effective. You will reach behavioral changes, but it will take time. So we don't have enough staff to do this, so not everyone can do this. But it's really the one showed in studies that you can have a long-term efficacy and you can get the whole hospital on board if you spend time talking to each one, which is somehow impossible. Formulary restrictions and pre-authorization, this is the easiest way. The majority of us doing this in our hospital, it's A2 evidence. What we mean by formulary restriction, you wait till they order meropenem, then you stop it. You say you either have to have a clinical pharmacist, infectious disease, or clinical microbiologist reviewing the culture and said, yes, this is the last resources, they really need what they need. Everyone loves this. ID is busy, we're also so busy, we don't have time to spend one-to-one and do the first strategies. But this one we like it, but the other people in the hospital, they don't like it. You take the right to order whatever they want. There is other many elements you should combine when you should choose one of the strategy. Education, which is A3, and we're going to talk about education. It's either active or passive. Guidelines and clinical pathway, which is one form of the passive method of educations. You do guidelines. For example, we did a guideline on antibiotic prophylaxis, each surgery, what type of prophylaxis they should get, and if it's recommended or not recommended, and when they should stop, and the doses reflected by pediatric and renal adjusted. Pathway, how you treat diabetic foot, how you treat meningitis, and this is, trust me, very good for your GC clinic, general clinic, and emergency department. They need a pathway because they're seeing the bulk of the cases, and there where you have a problem and inappropriate use of antibiotic. Antimicrobial order form, again, this is if you want to do the formulary restriction, you may need antibiotic order form to facilitate things. Streamlining or de-escalating, and as Dr. Abir mentioned, start strong, and that's what I tell everyone. Start strong, nothing wrong if you don't know, start strong. But the problem is patient not improving, or the culture came up something else, and they said, okay, but patient improve on meropenem. They don't have the courage to de-escalate. What they need is just tap on their shoulder, especially in ICU patient. I always tell them, it's the patient in the right setting. He's in ICU. You can just detect minor change and put him back. So they need the emphasis of de-escalating. I found for 2 years now after coming from Canada, de-escalating is our major problem. They start strong. Never I've seen anyone step to narrower agent. Never. Okay, dose optimization, and again, when we did audit for our surgical team, we find they give some of them, they give the recommended antibiotic, but the incorrect dose. So dosing, we know that when you give an appropriate dose, you would put patient at high risk of resistance. Okay. Switch from IV to oral, it's again one of the area of weakness I think in our country we should focus on. Why I'm giving ciprofloxacin intravenously if the patient can take oral and he has no contraindication or he need to be MPO. You must emphasize on this. You must tell everyone, well, we have a lot of antibiotic that can be given orally, and you have the same bioavailability, the same level in the blood, like ciprofloxacin, fluconazole, metronidazole. Not all the time intravenous is the answer, and even in infection control, we do this for other drugs to prevent needle stick injury. So intravenous drug is not recommended anymore in the hospital. So from both ends, either you want to protect yourself from unnecessarily needle or sharp exposure in the hospital, or you want to do antimicrobial stewardship. Okay, now the two intervention that studies wasn't totally supportive is the antimicrobial cycling and combination therapy. Antimicrobial cycling, there was no good design and randomized control trial to support that. What do we mean by antimicrobial cycling? Antimicrobial cycling, for example, you notice you have in your gram-negative tigacycline resistant. So you'll say, I'm gonna switch to treat my soft tissue infection with the Clinda and Cipro for 3 months, then I'm gonna go back to tigacycline. It's very hard to design a study to know when should I switch, how long should I stay on the antibiotic, then how long should I switch, what antibiotic is the best to switch for, what my other competitor without decreasing the clinical efficacy. I think antimicrobial cycling, in my opinion, it may has a role, but the problem is we don't know how to do it, and there is no study to support that. Again, combination therapy to give 2 drugs to decrease the resistance. This have not been documented. We all know it's true for rifampin. You never treat any infection with rifampin alone. You always need to give 2 drugs. You need to add to rifampin or you will end up with resistance. But for other drugs, again, there is no studies show that if you use 2 drugs, some experts believe strongly about Pseudomonas. I'm not going to discuss this here, but overall, combination therapy is not well supported and not highly recommended by all experts. So if you want to do one of the 2 strategies, you must have education, guidelines, you must have order form or anything to facilitate how they know that this is restricted, the process that they should follow to have it approved. Streamline or de-escalate, do a lot on that, teach them, let them know why it's problematic, dose optimization, and IV to oral switch. Okay, now passive and active education. Studies show that passive education such as posters, guidelines, policy, lectures, didactic lectures, it can help, but it has minimal efficacy. Active, which one-to-one hands-on training, interactive role-playing, interactive sessions showed to be more effective in terms of long-term efficacy. You will give guidelines, they will follow it 1-2 days. This is a passive, they will forget it 6 months later. You have to re-emphasize. So if you want to spend a lot of your time, try to do something active. Electronic learning, where they read a scenario, they have a question at the end, something to keep them challenged and tuned all the time. Okay, antibiotic care bundles. So this is what I'm going to focus on now. Bundles, we have a lot of bundles in infection control. What do we mean by bundles? They group all the intervention that showed to decrease infections or to prevent negative consequences. They group them all and they put them in a bundle, and you have to implement it in the same time for all patients. There is no pick and choose. If the hospital decided that this is the bundle I will follow for ventilator-associated pneumonia, then it's all or none. You cannot choose any element individually and implement. It's the same for antibiotic care bundles. So antibiotic care bundles, it's covered 2 ends. It's acute care and your surgical patient when they're going to prophylaxis, to their OR and they receive the surgical prophylaxis. Acute care, you want to select the most effective drugs and at the same time that help your patient cure in a timely manner. And at the same time, you want to reduce the side effect, whether it's nephrotoxicity, whether it's drug-induced fever. You don't want them to end up with a C. difficile, or you don't want to put them at risk of being colonized with a multi-drug-resistant organism. This is when you order antibiotic for treatment. The other arm, and to have a care bundles, you have to cover your both acute care and your surgical patient. You want to start the patient on prophylaxis, the right prophylaxis. For example, we found in our hospital the majority of the surgeons, they like cefuroxime, or the recommendation to give cefazolin. We still back and forth trying to change that, although we had a published guideline for around now 6-7 months, but still we're back and forth with the surgeon. You need to give it in the right time, which is 60 minutes prior to the surgery. If you're going to give beta-lactam, if you're going to give vancomycin, it should be 90 minutes prior to the incision. You must make sure that they know they cannot give the patient antibiotic and right away do the incision. The incision should be minimum 30 minutes to 60 minutes prior to the incision to give them the highest concentration of the drug at the incision site to reach the maximum efficacy. Same time, the same things. You don't want them to be predisposed to multi-drug resistant organism in the future. You want to make sure that you stop it right away after the surgery. Majority of our surgeons, they keep it forever. If the patient's there for 3 weeks, a month post total knee replacement, they will continue antibiotics. So you want to make sure that this practice is not happening, because this will put them at risk of having multi-drug resistance in the long run. Okay, so acute care bundles, under it has two elements, either on initiations and on continuation. It's similar to what we do with the central line bundles when we have on insertion and on continuation or maintenance. So on initiation, you have to have the clinical rationale documented. So if you want to implement this, make sure that you have a form, or we're building a software in our hospital to reflect this. It's taking so long now, but we've been going through a Canadian accreditation. It was tough on the IT team, so inshallah, sometimes we're going to have this electronic. So whoever want to order antibiotic, he has to answer the following questions. Clinical rationale, what is the diagnosis? Appropriate, did you send the right samples? Usually they think it's meningitis, and it'll be done 2 days later or something. They think it's abscess, and they drain the abscess, the surgeon, and they don't send for culture. So this is a reminder, you cannot order the antibiotic unless you did all this. Adherence to prescribed guidelines. If you have a guidelines, they will say yes or no, for example, the surgical. Additional intervention done. Did you do drainage? Did you do surgical? This also should be documented. On continuation, so for example, if you decided that meropenem will be given, then it will be reassessed in 48 hours. This will appear, and they should say, did your patient improve, yes or no, or the same? Did you consider de-escalation, yes or no? Did you consider switch to intravenous to PO drug? So this is on reordering, it should be done. Okay, this is a nice study done by Celine, a French physician. She did measure the compliance with all what I mentioned, and she found it effective when she told her staff at the hospital that you have a 66% compliance with the bundles. They wanted higher, so people work to make it more. So they have, for example, here, if you look at documentation of rationale of starting the antibiotic, it's 138 said yes, there is a documentation. 112, they have no documentations. Okay. Is it working if you tell your people their compliance rate? Yes, and this is again was shown by a study done by Teen and published in the healthcare journals in 2010. They looked at 160 patients who received for over 400 orders of antibiotic, and they found when they measured, they did the audit and they measured the compliance, and they report back de-escalating, which one of the things I believe we have a weakness here in the kingdom. the de-escalation increased from 72% to 90%, and that was significant. So yes, try to do small audit, measure the compliance, and report back, and go from there. You will get everyone attention when you do that. Okay, this is very important. You cannot say stewardship and fight for stewardship. We want to control antibiotics, and you don't have a tool designed ahead. So when you design which strategy you want to go, design how you're going to measure the efficacy of this process. Because one time someone will say, and I had this when I started working on the antimicrobial stewardship in the hospital. They will say, we had a patient and he died because ID prohibits him from his right of antibiotic. And initially that's what been told to me. He died because ID took his right. We killed the patient. You have to document that. You have to make sure that you're measuring, you have something to measure that. So you need process measure. You want to make sure that the intervention that you use really change behavior. So if you did restriction and you still have increased order or more order of one drug, that means your intervention is not well implemented. Okay. In order to help you to do that, yesterday over dinner someone mentioned the IT. Yeah, IT is needed very much. If you cannot have an ID, there's a very nice study done by Celia. It's day 3 bundles. So when they order antibiotic, they get the pharmacy will send us stickers on it. You document the antibiotic rationale, you put the right dose, and you put if the patient improve or not. And they found when they did this, this is help you. If you want to look for one of the method for process indicator or performance indicators, stickers or order forms is one of the way you can utilize. Outcome measures, this is very important, especially for administrations. Mortality, as I said, no one will tell you, Wallahi, you killed the patient. You said we had no change in mortality or no increase in mortality secondary to infections or inappropriate use of antibiotic. Readmission rate, if someone was placed on narrow agent, ciprofloxacin or whatever, and if he admitted back because he needed meropenem, you have to have a system in place to monitor for that. Your multi-drug rate, if it's dropped, but this, it's not easy, you cannot right away detected. It's nice with the antibiogram, which I'm going to mention in a second, but don't put the multi-drug resistant changes right away. Don't think you don't want to get discouraged right away. You don't want to start and say, Wallahi, MRSA will decrease by 50% in 1 month or 2 months. Make it a long-term plan, a year plan. Like at the end of the year, we're going to have a 20% reduction in our MRSA. When you start gradually, you won't get discouraged, and you'll be happy if you reach higher than that. Length of hospital stay of your patients, adverse event. How many of your patients end up with anaphylaxis shock? How many of your patients have drug-induced fever, which we've seen a lot. 70% of drug fever is related to antibiotic. And eventually it's the cost, which is your winning card with the administrations. Okay, what's the microbiology role? Microbiology has a very, very big role in that. It's A3 evidence. It's when they report in timely manner. When the report, turnaround time for report, it comes on time, this is helping in stewardship. When they release the correct report, when they help in outbreak and surveillance, this is very important in antimicrobial stewardship field. This is one example of our nice report by the microbiology department. As a stewardship, it's not well presented, but here it's the ESBL, what stayed here. This is a multi-drug resistant organism. Please follow infection control precautions. So the nurse will initiate right away. She doesn't wait for infection control to come and put the sign. And we put the right treatment. We never, especially for non-sterile site infections, we never put meropenem unless needed. If meropenem sensitive, we hide it. So this is one of the way microbiology can participate in the stewardship program. Okay, and this is another example, MRSA. لا يا شيخ. Okay, okay. Okay, antibiogram is very, Okay, antibiogram is one of the tools that help in antimicrobial stewardship. So your ICU will know they don't have to start colistin. 90% of their cases, they're ciprofloxacin sensitive, so they can do that. This is very important to be done annually. Precolcitinin, it's one of the, studies showed it does have a big role in antimicrobial stewardship program. It can help tell you if the patient have infection or no. It can tell you if the patient should come into the hospital for antibiotic or can be managed with antibiotic as an outpatient. And there is so many randomized clinical trial to support that. Precolcitinin found in the body less than 0.1%, less than 0.1. If you have infection, it will increase. This is one of the largest multi-center studies that I came across, and it's very good because it's multi-center. It covers Switzerland, other cities in Europe, other countries in Europe, as well as United States, and it showed when they implemented precolcitinin and for lower respiratory tract infections, they had a better control of infections. They have no change in mortality. They have they found that sensitivity and specificity for precolcitinin is 90 to 95%. Again, I apologize for the quality of my graphs, but here they divided the patients to groups. If you have precolcitinin less than 0.1, then you don't have to be treated. You don't have infections. If you have the precolcitinin above 5, then you have to be admitted for antibiotic. Okay, sorry, I have to skip quickly because I'm running out of time. It has its pros and cons. It has false positive and false negative. If they will give you false positive in neonate, it will give you false positive in your patient have serious or acute respiratory distress. It can be negative if you have early infections, if you have a fungal infection or early or localized infection. Okay, so what we did in our hospitals, we have a policy. We spent a year designing a policy. We looked all over the place. I have my professors in Canada. They were, God bless them, wallahi, they helped me a lot. They sent a lot of forms, a lot of templates, a lot of guidelines. And we, based on our local antibiogram, based on what I got from Canada, we managed to get a very strong antimicrobial stewardship. We had start restriction gradually because we had prior bad experience. All professors refuse antimicrobial stewardship. So we decided to start with the unit they don't know of what the patient on, the surgical team, and we restrict the antibiotic, and they didn't even know that they have restrictions. And when that succeeded, we went to OB/GYN team. They welcomed that, and they didn't have a major, and initially they didn't have any problem with their antimicrobial prescribing behavior. We moved to PEDIA, and now we're starting with the medical for a month now. For ICUs, because we found that they're very tough. Now for a month, the ID team and myself, we start doing prospective audit with intervention. Myself, I go with the ICU team for Sunday and Tuesday in the morning round from 8 to 10. I just review each case with them and say, do you think we should try this? It works sometimes and it won't. I won't get discouraged, we'll keep trying, but we decided to do with the ICU prospective audit with intervention. Thanks God, this week managed to get a pager for antimicrobial stewardship, so someone will be carrying pager just to approve antibiotic. This is the number 4729. I know the ID's fellows hated me for that. Shahada's your one. Shahada, one of our ID specialists, is very good, and for him, he took the pager this week. We are working on the electronic approval system. Okay, so just to show you, this is one. I never had this done. Usually I finish quickly. Okay, so this is just to show you. This is before we have the restriction for the antimicrobial and surgical team. This is the uses. Meropenem, it was over 2,000. It dropped to 13,000, and we have the cost to support. This will be submitted to administration to help us more in terms of the IT support and other stuff. Okay, you need tools Whenever you're doing this, as I said, you need your IT, develop checklist, bucket card, antibiotic bucket card, antibiotic campaign and posters, and we just had antibiotic campaign in December in the hospital. Just tell everyone, including my family, antibiotic is not an M&M's. I have my father who convinced, although he's a military, he's a diplomat, he convinced if he take one amoxicillin, when he have a flu, it will help him. Despite what I tell him, despite the study I show him, this is what he believes. So please emphasize this, start with your family, it's not an M&M's. They look colorful, but they're not. Take-home message, antimicrobial prescribing care bundles are very good and useful. Should start it, but start it gradually. Combine this with performance measures. These are some references if you're interested. Okay, thank you very much.